All right, our next speaker is Dr. David Partrick, who will present on thoracoscopic thymectomy for myasthenia gravis. And this certainly has come a long way from when I was doing thymectomies with a median sternotomy and closing with wire. And, you know, it was a huge deal. It probably still is a big deal, but much less invasive the way you do it. So Dr. Partrick is a professor of surgery in the pediatric surgery division. He's a native of Idaho, did his undergraduate and medical school training at the University of Washington, and then came to the University of Colorado for general surgery and pediatric surgery fellowship. He holds many leadership positions within the hospital as well as within the division of pediatric surgery. He's director of surgical endoscopy. He's director of clinical operations for the division, and he's the pediatric surgery residency program director, the director of one of the best and hardest programs to get into, by the way. So Dr. Partrick, thank you so much for giving this talk. We look forward to it.
Thank you, Dr. Schulich. I'm gonna share my screen here, I think. There we go.
Yeah, it's coming.
Great. Still getting used to these Zoom meetings. I was going to mention, just going back to Dr. Naylor's talk, I'm looking forward to working with him more in the realm of this relatively new position for me, which is the Pediatric Surgery Fellowship Director. I would mention we just went through our interview season, obviously, and did all of our Zoom meetings, and it was kind of an interesting process. One I'm not sure if there's a lot of it, but one advantage was we had a few fellowship applicants, and one specifically who was actually interviewing from Chad, Africa, doing their international medicine work over there. And so in some ways, those virtual interviews are very helpful for some of those applicants, I would say, in terms of the travel issues involved. But look forward to more information along those lines. My talk, compared to Dr. Naylor, who's always difficult to follow, mine's going to be a much more focused talk, and probably something that a lot of faculty may not have a lot of experience with, but it's one of the things that, again, just touting pediatric surgery, we do get a lot of exposure to in terms of non-cardiac thoracic surgery as well. And this is a program that I've been involved with since finishing fellowship, and as Dr. Schulich mentioned, helping to develop more minimally invasive approaches to thymectomy, which historically has been a very invasive procedure. I do not have a slide stating this, but I do not have any conflicts of interest. So just as a background, myasthenia gravis is an autoimmune chronic neuromuscular disorder, which is characterized by production of antibodies directed against the postsynaptic nicotinic acetylcholine receptors on voluntary muscles. And this really does only affect voluntary muscles, not involuntary muscles. The blockade of those receptors then results in progressive voluntary muscle weakness and fatigue. And I'll talk about the kind of stages of how this works. In general, patients will develop, one of the first things they develop are ocular muscle weakness with ptosis and double vision. Can progress then to difficulty chewing, swallowing, speaking, and then eventually even breathing. Limb weakness, both upper and lower extremity limb weakness can be part of this as well. The natural history is that these symptoms often worsen with physical activity, and tend to improve after rest or even after a good night's sleep. Patients will often notice that their symptoms are improved after that. But myasthenia gravis is a debilitating disease. It means grave muscle weakness, and it's characterized by rapid fatigability of voluntary muscles, and in severe cases, respiratory compromise. With medical therapy and what I'll be talking about in more detail, surgical therapy, hopefully that's becoming much less and less common. This is a group of patients, obviously, we work very closely with our neurologists with. We have a very large group of neurologists at Children's, lots of them involved in seizure disorders and some other more common things. but at least a couple that are very involved in these myasthenia patients. The criteria in terms of how these patients are categorized in terms of the severity of their disease, as I said, the first stage really is extraocular muscle involvement. Sometimes their initial presentation will just be with ptosis and sometimes with diplopia. And then the second stage is kind of split into A and B, and it is a bit of a subjective grading system, but 2A is mild generalized muscle weakness that can involve the ocular, bulbar, or skeletal muscles, not respiratory muscles at this point. And then stage 2B, which is a moderate generalized muscle weakness. So again, it's a bit subjective. But then at stage 3, that's where there's severe bulbar, skeletal, and now respiratory muscle weakness. And this is typically characterized by an acute onset within 6 months or so for that stage 3. Stage 4 is more severe late myasthenia gravis, and we don't see this as much anymore, but this is disease progression over 2 or more years with rather severe clinical outcomes. The prevalence of this is about 14 to 20 cases per 100,000 people. These are really specific US numbers. So in the United States, there's between 36 to 60,000 cases, although, you know, looking at this, it's likely underdiagnosed in the entire population and certainly in the entire world, with the prevalence likely being much higher than this. Children, depending how you define children, account for 10 to 25% of these myasthenia gravis patients. The medical management, again, kind of targets, obviously, the underlying biochemical problem. Almost all of these patients that I see are on mestinon, which is an acetylcholinesterase inhibitor, pyridostigmine. And this is usually the first line therapy for all of these patients. Depending how they respond to that, then these patients often will end up on steroids, with the idea that they start off on a relatively higher dose of steroids to get their symptoms controlled and then gradually taper this over time. If they are unable to taper off the steroids, then other immunosuppressants can come into play: azathioprine, mycophenolate, methotrexate. And then for acute exacerbations, and these are typically patients who are hospitalized and even in the ICU, they might end up on plasmapheresis or on IVIG therapy. So that's largely the medical therapy. All of these medications, especially the steroids, can have significant side effects, and some of those are even much more of a problem in growing children. And that's where surgical management comes in. Dr. Blaylock, who most of you are likely familiar with, was really the first one to describe thymectomy to treat myasthenia gravis in 1939. He actually removed the thymus via sternotomy, of course, in a patient that had a thymoma, had a thymic tumor, and the patient's myasthenia gravis symptoms got significantly better afterwards. And then subsequent to that, his colleagues decided we should just remove more of these thymuses in patients, even without a thymoma or without a tumor. And they published that series about 5-6 years later, again, showing that even without a thymic tumor, these patients often got better after removing the thymus gland. And really, since then, thymectomy has played a central role in the management of medically refractive myasthenia gravis. Compared to adults, in general, the rates of remission and clinical improvement after thymectomy are actually higher in juvenile myasthenia gravis. And there's definitely an argument that earlier intervention may be more effective in these patients compared to even adults. Just briefly talking about the thymus gland itself, and many of you are hopefully somewhat familiar with this. The thymus is involved in T cell development and production. In patients with myasthenia gravis, the thymus is often hyperplastic, and that's a pathologic finding in about 60% of patients. It's only about 10 to 15%, and I would say closer to 10% probably of myasthenia gravis patients that actually have a tumor or a thymoma that you can actually find pathologically, sometimes diagnosed preoperatively with a CT scan. Some of the when you talk about what's the mechanism, why does thymectomy help these patients? It does go back to the function of the thymus with these T cells. Some of the neurology literature really just talks about doing a thymectomy actually helps to rebalance the immune system. I'm not sure if that's a real scientific way to look at it, but that's kind of how they describe it. In general, doing a thymectomy does not result in instantaneous improvement of these symptoms. It typically takes several months, if not several years. And so following these patients postoperatively for a significant period of time is very important in terms of following their symptoms. So with thymectomy, what has been demonstrated is that about 70% of patients, and this is primarily in adult data, 70% of patients have complete remission or at least significant reduction in the medication within 1 year of thymectomy. The American Association of Neurologists have stated that patients who have thymectomy are 2 times as likely to experience remission as those who only have medical treatment alone. So in general, and I think this does vary somewhat from institution to institution, probably depending mostly on the neurologists, as well as maybe the surgeon's experience with these procedures. But thymectomy is recommended for all patients less than 60 years old that have mild to moderate symptoms. And in general, it's most effective if performed within 6 to 12 months after the onset of symptoms. So not as good to wait years and years on medical therapy before these patients are coming to surgery. Historically, as Dr. Schulich mentioned, these have typically been done from a transsternal approach, and our cardiac surgeons are obviously very aware of this because they see that thymus and often remove, if not all, but a significant amount of the thymus, sometimes doing their sternotomy procedures. That's certainly a relatively morbid procedure, and I think especially in children, historically, that has limited how many kids would get referred for this procedure, since it is seen as such a morbid procedure. People then develop different, less invasive ways to approach this, a transcervical approach. Sometimes there'd be a combined transsternal and transcervical approach. And then when people did start doing this thoracoscopically, sometimes they would combine the thoracoscopic and the transcervical approach. However, over time, and probably really within the last 10 years or so, just an isolated thoracoscopic approach has become more common and relatively well described in the adult literature. Very few just case series, mostly in the pediatric literature, which is why we decided to look at that both with our neurology group. And then one of our pediatric surgery fellows who finished with us going on 10 years or so now, went back to Mayo Clinic when he finished. And so I actually worked with him because at Mayo, they, as you are all probably aware, have a very good system of tracking historical cohorts. And they had a relatively good series of open thymectomies in the past there that we could compare our primary thoracoscopic approach that we have been doing now for about the last 20 years. So we went back and looked at all children less than or equal to 19 years old who underwent thymectomy at 2 geographically separate academic institutions between our hospital here at Children's Hospital, Colorado, and at Mayo Clinic. The diagnosis was based on history. Diagnosis of myasthenia was based on history, physical exam, EMG studies, circulatory acetylcholinesterase receptor antibody levels, and the tensilon test, which is a response to an anticholinergic agent. The surgical indications were clinical deterioration or failure of medical therapy alone. Open was defined as either transsternal, transcervical, or any type of mix of those procedures. I'm going to actually drop off of here for 1 second and go to a different screen here if I can. I do have a video that briefly shows this, and it's relatively cropped, but just this is a left thoracoscopic approach. So the key is avoiding this phrenic nerve, which is coming down. That's absolutely necessary. This is opening the pleura, grabbing the thymus right there, which is that fatty looking material. Sometimes a little difficult to differentiate from the surrounding fat, but in general, you can do that pretty easily. The main vessels, the main draining vessels are going right into the brachiocephalic vein. I'm using the ligature device here to kind of take some of, that's the brachiocephalic vein right there. There'll be a better view of it later. This is again approaching it from the left-hand side in the anterior mediastinum. Typically very easy to bring it off of the pericardium, but you do have to extend the dissection all the way to the contralateral side. I like going on the left side because I think you get a much better view of this brachiocephalic vein doing that. There's a good view of it there in one of the branches that's draining from that thymus gland. You can easily extend this well into the cervical region. I don't think there's any reason you can't get a complete thymectomy doing it this way. And as you can see, a very nice and detailed view of those things. And then we view the anatomy, and then we typically put it within a bag and deliver it back from the chest. So let me come back to my talk here. Bring that back up again. So as I mentioned, at least at Children's Hospital, all thymectomies were performed using a left-sided thoracoscopic approach. Patients were in a modified right lateral position, kind of elevated at a 30 or 45 degree to help the lung drop away from the anterior mediastinum. Typically, you do not need to do lung isolation for this, just a relatively low intrathoracic pressure of 5 millimeters of mercury will allow the lung to drop far enough from the anterior mediastinum that you have excellent visualization. 3 5-millimeter ports are utilized in the anterior axillary line. And as I mentioned, it is key to avoid phrenic nerve injury in these cases. That's key in any patient, but especially in a myasthenia patient who's already going to be at risk for potential respiratory muscle weakness and things. If they get a phrenic nerve injury, that can be obviously a devastating problem. Chest tubes are typically removed intraoperatively as there's no real risk of an air leak after these procedures. So when we looked at our results from this, again, it's a relatively unusual or rare diagnosis, but over our study period, again, between the two institutions, we had 18 patients who underwent an open thymectomy and 16 juvenile patients who underwent a thoracoscopic thymectomy. The only difference between the two populations were that the open thymectomy patients were somewhat older, just over 15 years old compared to 12-year-old in our thoracoscopic cohort. I have a feeling, again, this is the open thymectomy patients were somewhat of a historical cohort. I do think the neurologists are sending these patients sooner to surgery now for the thoracoscopic approach. This myasthenia gravis does tend to be a bit more common in females at this age, although that was not a significant difference between the two groups. Preoperative symptom duration was, again, between 10 to 11 months, so still less than a year prior to surgery. I would argue it maybe should be shorter than that. All of these patients, by the time they came to surgery, were on cholinesterase inhibitor, Mestinon, as I mentioned earlier. About 50% of them were on steroids preoperatively and had to be stress dosed. And then going back to that Osserman staging that I mentioned, again, stage 1 being just ocular manifestations, and stage 2 and 3 advancing from there with stage 3 including respiratory muscle weakness. You can kind of see the split there, but no significant differences between the two groups. Most of the patients in both groups coming to surgery were really within the stage 2 Osserman criteria. And then in terms of the actual operation, we did see that the operative time was about 30-35 minutes longer in the thoracoscopic group. But the intraoperative blood loss was significantly less in the thoracoscopic group compared to the open group. None of these patients required postoperative ventilator management, and the majority of these patients had their chest tubes removed intraoperatively without the need for a postoperative chest tube in both groups. The other significant differences were decreased duration of IV narcotics by about 4-fold in the thoracoscopic group, and then a decreased length of stay by a little bit over a day in the thoracoscopic group. A lot of these patients will go home the following day after surgery. Some of that does depend on how they do under anesthesia with their respiratory symptoms, if they have any of those. Follow-up was on average a bit over 4 years. And over that time, Again, no difference between the group. Somewhere between 35 to 38% had complete remission after the thymectomy, but nearly 100% had at least clinical improvement. And I'll drill down on that a little bit more. We had no mortality from either of these groups. In terms of improvement afterwards, there's this DeFilippi classification that has been developed to look at improvement in symptoms basically after thymectomy. And one is complete remission, where the patients have no need for medical therapy afterwards. And again, that's just upwards of 35 to 40%. In stage 2, this is probably the majority of patients where they're asymptomatic and they've been able to reduce their medication load. And then there's a few others that are improved, but still on significant medical therapy. And one patient in the open thymectomy group who was actually worse. But again, that's an unusual scenario. So those are the outcomes that we saw, which really does mirror what's been demonstrated and actually is in the adult literature. And I was going to say is improved in children, which has been reported in the past, at least in smaller series. This is really the largest series comparing open versus thoracoscopic thymectomy in children. So what we conclude from this is, well, summary at least, thoracoscopic thymectomy is a safe and effective surgical treatment for the surgical technique for the treatment of myasthenia gravis. Again, the goal of the operation is to do a complete thymectomy, not leave any of the thymus behind, but to do this in a safe and hopefully less morbid fashion than a sternotomy, which at least historically has been the gold standard. Thoracoscopic thymectomy resulted in less blood loss, a 4-fold decrease in duration of IV narcotics, and a shorter length of stay in the hospital by more than a day. Clinical improvement in remission rates appear similar to between the two approaches, which would again argue that a complete thymectomy is being accomplished doing this thoracoscopically. So utilization of this minimally invasive thoracoscopic approach may result in increased acceptance of thymectomy, both by patients and by referring neurologists, hopefully enabling earlier surgical intervention and decreasing the need for long-term steroid use. That's what I have. Certainly happy to answer any questions.
Dr. Partrick, excellent talk. And I have a couple of questions. So being a surgical oncologist, my question is, has anyone tried to irradiate the thymus along the way? I'm sure that may set up a lot of problems for the future, but I bet you at some point along the way, somebody said, you know what, let's ablate the thymus with high dose radiation. So why don't I stop there and then I'll ask my other questions.
Yeah, I have not seen that, Dr. Schulich, and it's a good question. As you know, that would probably be viewed, especially in the pediatric age group, as being a relatively morbid thing. And we obviously see that with some of our oncology kids now with different tumors where they get total body irradiation. Yeah. But I do not think I have seen that. Now, it is interesting, as you're well aware, you know, the thymus is a quite large and active gland in young kids and tends to involute over time. It seems like that involution is somewhat halted in these patients. So it does raise the question of, you would think in an adult that irradiation might not do a whole lot to the thymus, but in these patients where it still remains somewhat hyperplastic, I think it certainly does.
Yeah, I mean,
hey, Dr. Schulich,
I personally think it's a bad idea to do that, but I bet you somebody. I think
the neurologist would say that too, probably.
Yeah.
Hey, Dr. Schulich.
Let me just follow it up with one more question, then I'll turn it over to Dr. McIntyre. The other is, when was the first patient entered, what's the oldest patient? How long ago was the first patient in your database?
So in our database at Children's, it was really 2001, which is when I finished fellowship. In the Mayo Clinic database, it went back into the early 90s. I don't know. Beyond a 4 or 5 year follow-up, I'm not sure if we have that follow-up beyond that, but I don't know if that's what your question's leading to. But
so my question is, without a thymus, if you take out the thymus, because it's responsible for the education of T cells and other immune cells, are they more prone to cancer, less prone to cancer, more prone to lymphoma and leukemia, or less prone to lymphoma and leukemia? That's something that you could easily do with this cohort of patients.
We could, and I think it's actually a great question. That's been a theoretical concern, as you're bringing up, I think, for all of these patients. And it actually comes up with some of the discussions with these families when they, as you might know, once they Google a lot of this stuff, they'll start coming up with these questions themselves. I do not think that's ever been shown in any study, but this might be a database where we could do that. And part of the problem is every institution has relatively small numbers, but
you, I mean, you have a decent database from 30 years ago, starting 30 years ago. I mean, some of those teenagers are now, you know, in their, 40s, right? So right. I think you could start answering that question. Okay, I'll turn it over to Dr. McIntyre.
I just was going to comment. I think you're being maybe a little coy that thymus radiation was actually pretty commonly done in the 50s and early 60s not because of myasthenia gravis, but because there were kids who had very large thymuses, and that was thought to be abnormal. So people radiated it, and you saw a big increase in thyroid cancer about 25 years after those kids got radiation to their thymus.
Yeah. And also it was done for transplantation, right? In the early experience for transplantation too.
Right. And then Trevor mentioned on here, thoughts on robotic assistance. This has clearly been done with robots as well. And there's plenty of people advertising that on the internet. For myself and for the children we work with, you know, the robot comes with mixed results just in terms of size of the platform and everything else, but it's definitely something that can be done with robotic assistance. I personally don't find that markedly helpful without a lot of suturing and things that really isn't necessary in this procedure, but it's definitely been described. And then Ron Gill mentioned, it turns out that there is considerable extrathymic T cell education, which is correct. So even after the thymus comes out, it's not that you lose that function entirely. Absolutely right.
Awesome. Okay, 2 great talks. Thank you, David. And I look forward to hearing a resummary of this in 10 more years.
Absolutely.
But it's really an interesting field. And I actually did a lot of thymectomies at Hopkins because that's where the indication for this operation arose. But it was all open, and it was a horrible slog for the patients. And what you're doing is, I think, so much better. And it just goes to show that we're evolving as surgeons and with surgical techniques. So thank you so much. Great talk. Everyone have a great day. And by the way, it is International Women's Day. And the reason I know this is one of the transplant societies has given Dr. Pomfret, Elizabeth Pomfret, an award for being not only one of the top leaders in transplant, but being a woman leader in transplant. So congratulations to Dr. Pomfret. Okay, have a great day. Thank you.